Our first presentation is entitled Laryngeal Tube versus Endotracheal Intubation in Adult Out-of-Hospital Cardiac Arrest, the Resuscitation Outcomes Consortium's Pragmatic Airway Resuscitation Trial, presented by my friend Henry Wang.
Good morning. Thank you for the opportunity to present our cutting-edge research. I'd like to acknowledge the co-authors of this study, who are not just colleagues but friends who have been loyal supporters of this work for the last 10 years as we have worked to bring this trial to a reality. Is this the correct clicker here? Give me 1 second. Okay. Let's try this. Forgive me, the screen here is different. Okay, I will need some AV assistance because none of the buttons here forward the slides. Could you do a slide forward, please? Try the keyboard. No, the keyboard's not working either. Let's try this. Okay, can you advance for me from the back? The study was funded by a grant from the National Heart and Lung and Blood Institute. Okay. The Ambu Corporation provided replacement laryngeal tubes for the study. They had no other role in the conduct or the execution of the trial. Endotracheal intubation is the most common advanced airway management technique used by paramedics in their treatment of out-of-hospital cardiac arrest. Intubation is the main event of resuscitation, the showstopper, the procedure that defines advanced life support care. Over 30 years ago, intubation became a standard part of paramedic care under the assumption that mirroring in-hospital practices would improve cardiac arrest outcomes. Can you advance to the next slide, please? Okay. However, intubation is a difficult procedure, and numerous studies illuminate its perils and pitfalls, including unrecognized tube misplacement and dislodgement, the need for multiple insertion attempts, and the linkages between intubation attempts and CPR chest compression interruptions. The provision of adequate intubation training and clinical experience also pose monumental challenges. Some paramedic students graduate from training without performing a single live intubation. In many communities, paramedics have the chance to intubate only once per year. Next slide. Okay. Newer supraglottic airways, such as the King laryngeal tube, LMA, and iGel offer appealing alternatives to intubation. These devices are easier to insert, require less training, and seem to facilitate ventilation similar to endotracheal tubes. To minimize chest compression interruptions, many EMS agencies have shifted to primary supraglottic airway insertion in the treatment of cardiac arrest. Given these practical considerations, one would expect supraglottic airways to demonstrate better outcomes than intubation. However, observational studies offer an unexpected finding. When you use observational data, intubation seems to do better than supraglottic airways. Remember that observational data are retrospective, non-randomized, and influenced by confounding, and therefore it is difficult to draw definitive conclusions from these studies. There have been no large-scale randomized comparisons of supraglottic airways versus intubation in out-of-hospital cardiac arrest. In this study, the Pragmatic Airway Resuscitation Trial, we sought to compare the effectiveness of strategies of initial laryngeal tube insertion versus initial endotracheal intubation upon outcomes in adult out-of-hospital cardiac arrest. We conducted a multi-center cluster randomized trial with crossover encompassing 27 EMS agencies from the Alabama, Dallas-Fort Worth, Milwaukee, Portland, Pittsburgh communities of the Resuscitation Outcomes Consortium. The study was conducted under federal exception from informed consent rules. Parameters of the grant award from NHLBI influenced the design of the study. most notably the emphasis on the use of standard practices and the focus on outcomes rather than explanatory mechanisms. The capped funding amount limited the scope of the study, including the sample size. The trial included adult out-of-hospital cardiac arrest treated by EMS personnel and requiring advanced airway management or bag valve mask ventilation. We randomized clusters to treatment with either strategies of initial laryngeal tube or initial endotracheal intubation. In the intervention arm, only the laryngeal tube was permitted for the initial airway attempt. We allowed rescue of failed airway efforts with any other available airway management technique. Select basic life support rescuers in Milwaukee and Portland were already trained in laryngeal tube insertion. For the trial, these clinicians inserted the laryngeal tube when their agency was assigned to the LT arm. And when the agency was assigned to the intubation arm, they performed bag valve mask ventilation. EMS agencies followed local protocols for all other aspects of airway management and cardiac arrest care, including confirmation of endotracheal tube placement. Cases requiring bag valve mask ventilation only were retained in their respective group per intention to treat principles. We organized the EMS agencies into 13 randomization clusters. Crossovers occurred at 3 to 5 month intervals. The primary outcome of the study was 72-hour survival, an endpoint that encompassed return of spontaneous circulation, as well as national recommendations for post-arrest care, including therapeutic hypothermia, coronary catheterization, and delayed assessment of neurologic status. The limited funding of the grant precluded powering for more definitive endpoints. Secondary endpoints of the study included ROSC, survival to hospital discharge, favorable neurologic status and hospital discharge, airway management course, and adverse events. We examined the data using intention to treat principles. We powered the study to detect a 4.5% difference in 72-hour survival, aiming for a total enrollment of 3,000 patients. Results. We enrolled a total of 3,004 patients, 1,505 assigned to the laryngeal tube arm, and 1,499 assigned to the endotracheal intubation arm. Patient characteristics were similar between the LT and the intubation groups. Protocol compliance was well over 90% in both arms of the study. Initial intubation success was 51% in the intubation group. Overall airway success was over 90% for both arms. Time to airway start and placement were over 2.5 minutes shorter for the LT arm than the intubation arm. 2/3 of the EMS inserted laryngeal tubes were converted to intubation in the emergency department. This plot summarizes the absolute treatment differences between the laryngeal tube and the intubation groups of the trial. Points to the right favor the laryngeal tube, points to the left favor intubation. 72-hour survival was almost 3% higher in the laryngeal tube than the intubation group. ROSC, hospital survival, and favorable neurologic status on discharge were also higher for LT than the intubation group. These differences were all statistically significant. These associations did not differ when stratified by a priori defined subgroups, including age, initial rhythm, witness arrest, bystander CPR, or response time. The per protocol analysis, retaining only those who received the correct airway in each arm, showed persistent differences in 72-hour survival. Because of slight imbalances in the group allocation, we performed a post hoc multivariable analyses adjusting for Utstein variables. These analyses suggested slight attenuation of the associations between 72-hour survival and airway strategy. There were similar observations in the as-treated analysis. There were higher rates of multiple insertion attempts, unsuccessful attempts, and unrecognized airway misplacement or dislodgement in the intubation group. There were slightly higher rates of inadequate ventilation reported in the laryngeal tube group. Pneumothoraces and rib fractures were more common in the endotracheal intubation group. Of note, there was no additional risk of airway injury or swelling reported with the laryngeal tube. Our study suggests better out-of-hospital cardiac arrest outcomes with the strategy of initial laryngeal tube insertion than initial endotracheal intubation. While we designed the trial to study 72-hour survival, we observed associations with LT insertion that persisted to more definitive endpoints, including hospital survival and favorable neurologic outcome. These findings have potentially important implications for out-of-hospital cardiac arrest care. If EMS practitioners used the laryngeal tube instead of intubation, the observed 2.7% difference in hospital survival would translate to over 10,000 additional cardiac arrest lives saved every year. We emphasize that the trial tested two strategies of airway management and not specific devices. And while the trial was not designed to study mechanisms, we suspect that the use of the strategy of the laryngeal tube resulted in efficiencies that influenced cardiac arrest outcomes. An important observation was the 51% intubation success rate, which would seem low compared to other EMS agencies. We are not surprised by this finding. In the effort to minimize chest compression interruptions, many EMS agencies advocate limiting futile intubation attempts and moving rapidly towards rescue supraglottic airway insertion. This observation is affirmed by the complementary overall airway success rate of over 92% in both arms of the study. However, this finding clearly beckons the question of whether the trial results would have differed in settings with higher intubation success rates. Because of funding limitations, we could not assess the influence of chest compression quality or ventilation quality. In this study, we studied the laryngeal tube and not other supraglottic airway devices. The post-hoc analyses suggest that random allocation imbalances observed in the study may in fact be important. And finally, the study pertains to the out-of-hospital setting, not the in-hospital setting. In conclusion, in this trial, we found that a strategy of initial laryngeal tube insertion was associated with better out-of-hospital cardiac arrest outcomes than a strategy of initial endotracheal intubation. EMS providers may consider initial laryngeal tube insertion as the primary advanced airway management strategy in the resuscitation of out-of-hospital cardiac arrest. Thank you very much.
Yes. The abstract is now open for questions, but because of our hard stop at noontime and the fact that we have 7 abstracts, we're going to have to limit questions to 2 minutes. So I suggest you line up before the speaker even starts. Any questions? Okay, is there a question? Okay, over here.
Can you hear me? Josh Gaither from the University of Arizona. Thank you very much. Wonderful study. My question regards the time to airway management. You reported approximately 11 minutes for placement of your airway. Does that reflect a primary non-airway resuscitation? So 8 or so minutes of a non-rebreather placed prior to airway management? Or was airway management early in your resuscitation?
We did not protocolize the timing of airway management interventions in this trial. All EMS agencies followed their standard procedures. In contrast to a prior study that we performed in the Resuscitation Outcomes Consortium, where there was a protocolized 8-minute period without airway interventions, no such protocols were applied in this study. The 11 minutes you see is our practical experience. It takes a long time from arrival on scene to mobilize the resources to care for the patient. So we are not surprised by this finding.
All right. Thank you, Henry.
Thank you very much.
Moving right along.